Thank you so very much, ma'am, for this very kind introduction. So I've been given a very interesting topic on innovations in Smile. I have no financial interest. I'm going to be dealing with this under the following broad subcategories. So let's begin with how to improve dissection techniques. Now, getting the lenticule edge right with subsequent anterior and posterior plane delineation is perhaps the most important step in Smile. The meniscus sign, as Professor Tityal has already elegantly alluded to, is simply a sign wherein you can see that there is an outer ring for the cap cut and an inner ring for the lenticule side cut. So in the lower right hand side, you can see that when the surgeon pushes the lenticule forward, it results in a meniscus shaped gap between the lenticle edge and the diameter of the remaining lenticular cut. Other signs that are described are the white ring sign, wherein the position of the white reflex relative to the instrument lets the surgeon know whether they are anterior or posterior. However, this warrants a uniform, good OBL throughout and also requires an additional oblique illumination in cases of dark irises. So we have described the SOP sign, wherein you can see that there will be a resistance between the dissected and the undissected halves of the anterior and the posterior plane, which does not allow the lateral movement of the spatula further. This can be seen at both the anterior and the posterior lenticular plane. Now, this is a contrarian surgical video wherein you will see the absence of a stop sign because the surgeon has gone on to do a posterior lenticular dissection in both attempts. So, following opening of the side cut, this is the first attempt wherein the posterior lenticule has been delineated. And you can see subsequently, because we are in the same plane, there is absolutely no resistance to the lateral movement of the instrument. Now, moving on to another controversy, which is addressing astigmatism in Smile. We're all aware that there is a lack of an active cyclotorsion compensation, because of which a number of manual compensation techniques have been described. So, what you see in the video is a triple centration, wherein the marks are placed well within the cornea as against limbal markings, and either 2 marks or 3 marks can be used. Now, a handful of studies have addressed this issue. The first showed significantly better results following cyclotorsion compensation in high astigmatism and cyclotorsion. However, one of the largest limitations of this study was that there was no control arm. It just compared with historical cohorts and it applied a 10% overcorrection nomogram, whereas the historical cohorts had no nomogram applied. Subsequent studies showed no statistically significant difference. Another study by Chen et al. Showed better outcomes. However, the cyclotorsion that was studied was very low with an average of about 2 degrees. So in order to overcome these limitations, we've done a contralateral study with patients with a high preoperative astigmatism and a cyclotorsion of more than 5 degrees. This is currently under review, and we have found no statistically significant difference in the visual outcomes. Now, one of the most important complications in the smile procedure is retained lenticules. If we have larger or more central remnants, it can result in irregular astigmatism, increased corneal aberrations with subsequent loss in corrected visual acuity. The use of an intraoperative ASOCT has been described. However, the lack of it being freely available and the cost are obviously potential limitations. Again, very thin lenticules may not be picked up easily with the ASOCT. The Circle software has also been described in a handful of cases where a conversion into a flap allows peeling off the retained fragments, but one obviously loses the biomechanical advantage that we had with Smile in the initial place. So we have described the use of an intraoperative wash with diluted preservative-free triamcinolone. You can see that the crystals beautifully deposit at the edges of the lenticule and allow subsequent delineation. The advantages would be that it is cheap, it's freely available, works even with thin lenticules, and also in cases where you might have some corneal edema secondary to excessive manipulations from the primary procedure itself. So this was a case where we had a 1.5 diopter correction, and there was a central steepening because of retained lenticule. You can see that the ASOCT has failed to demonstrate any lenticule. The patient did very well following the triamcinolone technique and resolved with an unaided vision of 20/20. Now, this is an interesting thing that I'd like to discuss is the off-label use of the Circle software. Now we're all aware that the Circle software is essentially made to convert the initial cap into a flap, which is then raised and ablated to treat any undercorrection or regression. So I'd like to show the off-label use of the Circle software, for two cases of suction loss. This is a suction loss during the side cut, during the smile procedure, wherein you can see that the superiorly encroaching conjunctiva has interfered with the femtosecond laser delivery and one does not have a side cut. We tried gaining access through a sharp-tipped instrument but were unable to do so. So the only thing that I could have done at that juncture was to abort the procedure. We instead decided to use the Circle software and converted the cap into a flap. Now, the important caveat to remember here is to do the delineation posterior to the lenticule, as one should not enter the junction cut and create a false passage. This cap, the flap, along with the lenticule, is now reflected. One can use a non-tooth forceps to stabilize the flap atraumatically and slowly go on to undermine the lenticule from the overlying flap. It is exceedingly important to spread the lenticule and make sure it has been removed in its entirety. You can see that there's a small sliver of tissue which was missing, which is subsequently removed, and the flap is reposited. Now, this is a rarer but another interesting case of a patient who was undergoing a femtosecond LASIK. So this is the first laser pass wherein we are making the flap, but there is a suction loss and we were unable to create the flap completely. As the femtosecond laser is exceedingly precise, you go on and read up the patient in the same sitting as the newly formed cavitation bubbles would percolate into the previously formed plane. So we've gone ahead and completed the flap cut, but again, because of certain movements, there is a suction loss and there is no formed side cut. So what could I do at this stage? I could either take a microkeratome and risk a biplanar flap. We could start with a femtosecond laser all over again and risk a potential suction loss, or do PRK at a later date. This essentially happened because I had run out of retreatment licenses and I could not make the side cut only. So what I did was I used the pattern A of the Circle software, which is only a vertical cut. The only difference was that I reduced the diameter by around 0.5 millimeters to compensate for any errors in subsequent centration. So you can see that we made 90-degree vertical side cut using the pattern A software of the Circle. This is then subsequently delineated from the underlying stroma as is done in a regular femtosecond LASIK. I'd also like to discuss the innovative uses of the lenticule. So we've described the use of the lenticule obtained for SMILE for intraoperative stromal augmentation in thin corneas of keratoconus. This is an epi-off procedure. It begins with removing the epithelium with a blunt spatula. The lenticule is obtained from patients undergoing small incision lenticule extraction for a myopic correction. All the patients undergo a serology for both hepatitis and HIV. Now, the lenticule that is procured is thickest at the center and thinner peripherally. So the placement should be such that the center of the lenticule overlies the thinnest area of the cone and an intraoperative stromal thickness of more than 400 microns is confirmed. Cross-linking, either accelerated or conventional, is done, and you can see that the lenticule, unlike a contact lens, remains firmly adherent to the underlying surface throughout the procedure. It is subsequently peeled off, the underlying surface is irrigated, and contact lens is placed. Now, having seen the safety and the efficacy of this procedure over a 5-year follow-up, we went on to combine it with the use of intracorneal ring segments in more aberrated eyes, wherein the best corrected spectacle visual acuity was poor. Other innovative uses that have been described is FILI, or the use of the lenticule intrastromally, both for the correction of hyperopia and also for the correction of mild to moderate cases of keratoconus in conjunction with cross-linking. So I just like to say that Smile is the future, and with a number of innovations, this technology is going to go places and it's going to be a lot of fun to be with. Thank you.